Good afternoon, everyone. Thank you for taking time out of your schedule today to join us for our webinar that will be presented today by Dr. Eller. Just wanted to go over a few things before we turn it over to Dr. Eller. Um, please make sure that your speakers are in mute to make sure that we're not getting any feedback noises. Also, just a couple reminders regarding our conference that's coming up for Healthy Mothers, Healthy Babies. It's our 45th conference that'll be taking place in Savannah, Georgia on this year. So the information is there. If you haven't registered, the early registration ends on August the 30th. So if you would like, go ahead and go to the website and go ahead and get registered for that. Also, GPA has a conference coming up. It's our 33rd annual conference taking place September 25th through 27th at the King and Prince Resort. So you can also go ahead and go to georgiaperinatal.org and get registered for that. So you can take advantage of the early registration for that as well. So at this time, I'm going to get out the way and go ahead and let Dr. Eller get started.
Okay, well, thank you very much, everybody, for joining. My name is Dan Eller. I am a maternal fetal medicine specialist in Atlanta, Georgia. My employer is Mednax, but I have privileges at some of the WellStar facilities at Kennestone and Cobb Hospital. And I've been in maternal fetal medicine is a subspecialty of OBGYN that deals specifically with high-risk pregnancies. And one of my interests along the way has been in ultrasound and in obstetrical ultrasound, and specifically in recent data looking at second trimester evaluation of cervical length for the prediction of spontaneous preterm birth. And certainly I'll just give you my opinion up front so that you don't have to wonder what I think, but I think the time has come to offer this to all prenatal patients who are having an ultrasound in the second trimester, which typically routinely happens to evaluate the fetal anatomy, while at the same time I would suggest that it's reasonable to do a transvaginal ultrasound to evaluate the cervical length, and hopefully by the end of this talk, you will agree with me. So without further ado, let's see if I can control this thing. Not yet. All right, I'm having a little trouble advancing the slide. There we go. Okay. So I don't know if I did that or somebody else did, but if I could just say next slide if we need to do that. But anyway, the primary objectives of today's talk are to help you to understand the impact of prematurity. This audience probably already well understands that impact, but we'll talk a little bit about, how strong of an impact that has had. Also to understand the challenge that we have in terms of predicting the risk for spontaneous preterm delivery. Unfortunately, we know a lot of risk factors, but we're still not very good at predicting those who truly will deliver early, spontaneously. And then I'll present some of the evidence to you for universal transvaginal ultrasound, and I'll also tell you what some of our organizations have suggested regarding universal screening. So if I could just have the next slide. So preterm birth, according to the Institute of Medicine, and this is from way back in 2006, so the numbers in terms of dollars is going to be much higher now. But in 2006, it was $26 billion a year. That's a lot of money. That translates into over $50,000 per infant born preterm, and like I said, it's probably much higher today as well. Now, the interesting thing is that in 2004, that's kind of when we hit a peak in terms of spontaneous preterm births, and it's kind of unclear exactly why. It seems that there were a lot more higher order multiples then. Our infertility colleagues have tried very hard since then to reduce those numbers in terms of like triplets and above. So that probably has helped, but really a lot of it is speculation. Another thing that has happened since 2004 is the introduction of 17-hydroxyprogesterone caprolate injections, in other words, progesterone shots, in patients who had a history of previous preterm birth to reduce the risk. So maybe that's helped as well. The large trial came out in 2003 suggesting that was helpful. So that may have helped as well. The nadir seemed to be in 2014 when it was down below 10% overall, but now it seems to be slightly climbing again. But even so, overall, there's been a 30% increase since 1981. Obviously, there's a lot more infertility treatment, and as a result of that, a lot more multiple gestations since then. Also, women are delaying childbearing, and there is a higher risk for preterm delivery in patients who are more mature. So that could be contributing as well to that slight increase since that time frame. So the good news is our neonatal colleagues have been very successful at improving their outcomes in treating infants who are born preterm and improving survival. There's not been as much success on the obstetric side in trying to prevent preterm births. Now, fortunately, with the advent of, or at least the addition of steroid injections, we've improved the outcome with that when they did deliver early. And we've also started to improve the neurologic outcome with the addition of magnesium sulfate for neuroprophylaxis in those babies who are born at under 32 weeks gestation. So we have had some advances, but not like the advances in the neonatal world. There are some places where the neonatologists are resuscitating 22-week babies. So that is occurring. Most places now are resuscitating 23-week babies and above. And then the decision also has to come in about route of delivery and what's best for, and nobody really knows, frankly, when the babies are that early, what's best in terms of delivery. Spontaneous preterm birth accounts for about 2/3 of all preterm deliveries. There are other indicated preterm deliveries when mom has a medical problem, or the baby's IUGR, or has a fetal anomaly that is causing problems in utero, or mom has preeclampsia, or uncontrolled diabetes, or some other type of problem that requires an indicated preterm delivery. If mom has non-reassuring antenatal testing, say the biophysical profile is abnormal for whatever reason, then babies may need to be born preterm. But still, the lion's share are of preterm deliveries, about 2/3 are spontaneous. So that's where our biggest problem is. So what about the rationale for measuring cervical length? Well, we do know from research that cervical shortening is one of the first steps in the processes that lead to labor, and they can precede labor by several weeks. Now, in the past, before we really understood cervical shortening, people assumed, and you still might hear people talk about cervical incompetence, quote unquote. Well, some of the cervical shortening may be due to that, but it's more like a risk factor for preterm delivery of all causes, potentially, or spontaneous preterm delivery of all causes. A decrease in cervical length in the second trimester is definitely predictive of that spontaneous preterm birth. And it's kind of on a continuum. The shorter the cervix, the higher the risk that mom will deliver early. Although it's not perfect because there are some women with a very short cervix who will go on to term, and there are other women with a long cervix who will deliver early spontaneously. So it is a predictor, but it's not a perfect predictor. Effacement does begin at the internal os, and that's why really you need ultrasound to evaluate the cervix rather than just a digital exam, because a digital exam is giving you the information about what's going on at the internal os. But if the cervix is closed, it's very difficult to tell the length of the cervix just based on a digital exam alone. And that happens very often. I will have patients sent to me where a pelvic exam was strongly suggestive of cervical shortening, and I looked with ultrasound and it was completely normal. I've also had the opposite happen, where a digital exam suggested a normal cervical length, but ultrasound was otherwise indicative of a short cervix. So that's why the ultrasound is much better at evaluating for effacement in the early stages. Vaginal progesterone definitely has been shown in multiple studies to reduce the risk of spontaneous preterm birth. And whenever you're talking about any screening test, number one, you have to have a screening test that predicts an outcome reasonably well. And then you also have to have an intervention that is going to help. I mean, we wouldn't screen for gestational diabetes unless we had treatment available that was going to affect the outcome, or hopefully affect the outcome. Well, here, fortunately, we have a procedure that does predict a risk, and then we also have a treatment that can potentially affect the outcome. So transvaginally, this top one is what a normal cervical length looks like. That cervix is about a little bit more than 4 centimeters in length. There are a couple of other things about this. There's no funneling whatsoever. If anything, the internal os sort of pushes into the gestational sac there just a little bit. This is the fetus up here. The black is amniotic fluid, and this is the cervix, and then this is the cervical canal that is being measured and you measure it. You need to get a nice sharp internal os, and then be able to see the external os as well to get a measurement there. Now you can see here that the cervical length is shorter, and you do have a little bit of funneling here. It looks like a little funnel going into the cervix. And then you also have a little bit of debris, and sometimes that can, in and of itself, that's not all that helpful, but it can be predictive that there may be some infection going on, or some blood that's collecting there, or something like that. But the main predictor is the cervical length. So that's really what you're looking for there. But you can tell the obvious difference between this normal one here and the shortened one down here. Here's some others. Again, this is a pretty long cervix and looks pretty good. So that one is, again, reassuring. You do have to, sometimes we will apply fundal pressure to make sure this canal doesn't start opening up in here, to make sure that we have a true evaluation of the cervical length. But this in and of itself is a normal appearing cervix. So what about screening, and how do we know for sure that it's helpful? Well, in 2016, there was a large review and meta-analysis. A meta-analysis, and it's a meta-analysis of randomized trials. Randomized trials are where subjects are randomized to treatment or not treatment, or evaluation or not evaluation, and it's random so that you don't get to choose which patients do what. Those are the best kinds of trials. They're also the most expensive kind of trials to do. And then a meta-analysis is when you go in and you evaluate all of the trials that have been done up to that time frame. So this was a review of several well-done trials, and it showed that vaginal progesterone treatment of women with short cervix did reduce the risk of preterm delivery less than 34 weeks. and it did it by 37%. And not only that, but really the bottom line is, are you helping the babies? And this meta-analysis showed that it reduced the neonatal morbidity and mortality by 41%. So this is sort of a study of studies that showed that indeed it does. Treatment, vaginal progesterone, did reduce the risk of adverse outcome in both mom and baby. So it also determined that the cervical length screening can be cost effective, even though most women do not have a short cervix. And about 30% of women, if you remember the numbers I showed you before, if you take all pregnant women, about 10% roughly are going to deliver early, and about 2/3 of those will be spontaneous. Well, this increases that detection rate by about 30%, who will deliver before 35 weeks without intervention if they have a short cervix. And the cost-effective analysis did suggest that we can reduce the cost of caring for those babies in the NICU if we start those moms on progesterone, because progesterone in and of itself is very, very inexpensive in terms of treatment. So interestingly, cervical length tends to be very stable between 14 and 28 weeks gestation, and it is normally distributed. The distribution at 20 weeks without prior preterm birth, if it's 15 millimeters, that's really, really short. That's half of a percentile. So if you think of your normal curve, 15 millimeters is way, way down at the bottom of that normal curve. 20 millimeters is at the first percentile, and 25 millimeters, which is what most people use as their cutoff to say short, is between the second and the third percentile. So that's kind of the numbers and what you're looking at in terms of predicting risk. A median cervical length is about 30 millimeters after 32 weeks, based or compared to 35 millimeters in that 22 to 32 week window. And prior to 22 weeks, the median is about 40 millimeters. Again, interestingly, it's not significantly affected by parity. We always think that the cervix kind of changes in a multiparous patient, and it does kind of on pelvic exam. But in terms of cervical length, there's not a significant difference. Also, race and ethnicity, even though we know that in the African American population, for example, the spontaneous preterm delivery rate is higher, in general, they still have the same distribution of cervical length as other races. And maternal height, even if a mom's short, that doesn't necessarily mean that she's going to have a short cervix. Or if a mom's tall, it doesn't necessarily mean that she's going to have a long cervix. Well, as I mentioned, 25 millimeters is usually the cutoff that we use. And we typically are looking at the cervix between 16 and 24, probably more commonly between 18 and 24 weeks gestation. Again, usually when we're doing their anatomy scan is probably the most effective time to do that, because you're already doing an ultrasound. So then you just add the transvaginal ultrasound to that. Again, as I mentioned earlier, there's no threshold below which all patients will deliver early. There was one study that showed that 25% of women, even with no measurable cervix, still delivered at later than 32 weeks. So a significant portion of these, even with no measurable cervix, delivered farther along. In another study where the providers were blinded to the cervical length, 82% of women with a cervical length of less than 25, remember that's what we use as a cutoff, and 50% less than 13 still delivered at 35 weeks or greater. So it's not a perfect predictor, but it does suggest increased risk. Well, here's what I was telling you about earlier, that sometimes you can be fooled and you can see a cervix, and this pouching is kind of a lower uterine segment contraction going on here. And if you have to wait until that lower uterine segment contraction relaxes before you're able to get an accurate evaluation and with a little bit of fundal pressure, it's starting to relax. It's still not completely relaxed, but you can already see that the residual closed cervix is a lot shorter than what it looked like initially. So you have to be very, very careful about that and make sure that mom is not having a lower uterine segment contraction. Unfortunately, it's good to do a transvaginal ultrasound with an empty bladder, but every time mom empties her bladder, she typically will have a lower uterine segment contraction. So you have to wait for that lower uterine segment contraction to resolve to make sure that you're actually measuring the true residual cervix. Well, universal versus selective cervical length screening. Why don't we just choose the highest risk patients and screen them? But there was a large study where they did do universal screening in singletons without a previous preterm birth. There was a decrease in the frequency of preterm birth at less than 37 weeks. And again, the adjusted odds ratio was 81.81, which means they were 19% less likely to deliver before 37 weeks and 22% less likely to deliver before 34 weeks and 24% less likely to deliver before 32 weeks. So this showed in essentially a low-risk population, because previous spontaneous preterm birth is our best historical predictor of spontaneous preterm birth. So in that particular study, it showed that it definitely is helpful to do the screening. If you just restrict your screening to historical risk factors, you would miss 40% of women with a short cervix. The number needed to prevent preterm birth is estimated at about 913 with universal screening versus 474 with only women at risk. So you don't really have to you have to double the number that you see in order to prevent a preterm birth. But again, that was calculated to be cost effective. And as you know, with a lot of our screening tests, you need to treat a lot of women or evaluate a lot of women evaluate a lot of patients before you prevent whatever the outcome is that you're trying to prevent. And the number to screen with 2 risk factors was 125. But that means that you miss a lot. You miss, again, 40% if you only do risk factors. But that's always a balancing act about when is it cost effective to do. Patients with a history of a previous indicated preterm birth, and this is interesting, they were still at increased risk for spontaneous preterm birth, even though their last pregnancy, supposedly it was an indicated preterm birth. In other words, because of preeclampsia or because the baby didn't look good or something like that, those patients still had an increased risk for delivering early. So what are our national and international organizations saying about this? Well, the Society for Maternal-Fetal Medicine has said that routine screening can be done. It should be done in patients who have had a prior spontaneous preterm birth. They also said that you can consider it, and it's reasonable with no history of prior preterm birth. They do suggest if a mom already has a cerclage, that there's no reason to continue to look at those patients with cervical ultrasound, transvaginal ultrasound, although I will admit that we still follow those patients. They also suggest you don't need to do it with preterm premature rupture of the membranes, because then that becomes your largest risk factor. The actual rupture of membranes becomes your largest risk factor for early delivery. However, it has been shown with a short cervix in the setting of rupture membranes, those patients will tend to deliver sooner, but it doesn't really change your management. You're still giving them antibiotics to try to prolong the latent phase, and you're still treating. Usually, leave them if they rupture after viability. You're usually leaving them in the hospital until delivery, and so on and so forth. So it doesn't really change your management. Also, with placenta previa, they suggest not doing routine cervical length ultrasounds, although it's not uncommon for us to reevaluate the placenta previa itself with a transvaginal ultrasound. They also don't recommend routine screening with multiple gestations because the data, there's no good treatment with multiple gestations with respect to multiples in terms of using progesterone and so on. Although there was a meta-analysis that came out after these recommendations in 2017 suggesting possible benefit. I will admit that when I find a short cervix in multiple gestation, I suggest to them that the data is not nearly as strong as it is in a singleton, but many times we will offer them progesterone with that caveat, and so many times they will go ahead and go on the progesterone. Cerclage, however, in some studies with multiples has actually shown an increase in risk of preterm delivery. So you have to be very, very careful and very, very selective with that. So, I lost my ability to, if you could advance to the next slide. There we go. So ACOG, they say that there's insufficient evidence to recommend for or against universal screening. Go ahead to the next slide. All right. So, ACOG doesn't discourage it, and if ACOG has to be extremely conservative because they're speaking not just for the high risk community, they're also speaking for every OBGYN in every clinical situation across the country. So they have to be very careful before they mandate any such screening. Although they don't suggest you can't do it, they just suggest that the data is insufficient to require screening. FIGO, on the other hand, does suggest, that's the International Federation on Gynecology and Obstetrics, they do suggest that screening is valuable and suggest doing it. The predictive value in test performance is roughly 35 to 45% in the absence of intervention, and it's higher when the cervix is less than 15 millimeters as opposed to the 25 millimeters that I mentioned to you. It's much better. The predictive value is even higher if they do have a history of a previous preterm birth. Also, cerclage has been shown if they have a history of a prior spontaneous preterm birth. It's been shown to reduce the risk of preterm delivery. So we do offer cerclage in the setting of cervical shortening with a history of previous spontaneous preterm birth. As an alternative, there are also some studies that suggest that progesterone, vaginal progesterone alone, may also reduce the risk in that population. So that is a reasonable alternative as well. Cervical length in the non-pregnant patient is not useful for predicting spontaneous preterm delivery. Usually our clinical approach is to have, in whatever situation you're in, it's good to have basically a protocol that you follow. And we do it routine transvaginal sonography, or offer it to all of our patients between 18 and 24 weeks. Sort of the ideal time frame would be 20 weeks, but 18 weeks is fine too. Whenever they're coming in for their evaluation for the fetal anatomy and so on. We offer vaginal progesterone in those with a cervical length of less than or equal to 25 millimeters and no history of preterm delivery. As I mentioned, we would offer cerclage to those who have a history of preterm delivery. The interesting thing is you still will have lots and lots of people offering bed rest. This has not been shown to prolong pregnancy in the setting of a cervical shortening. And in fact, there was one study by Grobman, who's part of the MFMU network, that showed an increase in preterm delivery in a group that was placed on bed rest as opposed to the group that was not placed on bed rest. So that definitely, obviously bed rest has a lot of downsides, increases the risk for muscle wasting, increases the risk for blood clotting, abnormal blood clotting, and will also drive the patient crazy. Not only that, but if the patient's working, especially at a sedentary job, and you take away their income by putting them at bed rest, that also can obviously be costly without any good evidence that it's helpful. Also, we found that cervical length measurements, for the most part, is not very useful after 30 weeks for predicting spontaneous preterm birth. Now, occasionally we will do it if mom comes into labor and delivery and is complaining of contractions, and if she does indeed have a long cervix, that in and of itself is predictive of low risk for preterm delivery in that particular setting. So what about technique? Well, I mentioned empty bladder. The transducer is gently inserted into the anterior fornix of the vagina until the cervix is visualized. And you want to avoid excessive pressure, and you want to enlarge your screen. And one of the ways to avoid excessive pressure is to go ahead and go in, and then once you see that it's being distorted, then you slowly come out until just where the vision is blurred a little bit, and then you go back until it's in focus, and then that's kind of where you take your picture. And then you take your, you usually want to measure 3 measurements, and you want to take the shortest of those. You have to enlarge the area of interest so it's at least half, and fetal membranes should be noted if they are present in the cervical canal. And obviously, the closed portion of the cervix is away from those membranes. You don't want to include those membranes in the closed portion. You should be able to see the entire cervical canal. I mentioned the withdrawal of the probe, and then you get your 3 measurements. And the fundal pressure, again, can help if there's a concern for what's called a dynamic cervix, where you don't really have, where there may be a portion of the cervix that's not really closed, as I showed you before on those previous pictures. So this is a totally normal looking cervix with no funneling, normal length, and so on. This is a normal looking cervix too. This is with fundal pressure. And the thing is you have to give them full credit. This cervix kind of curves a little bit, so you want to look at the whole entire cervix there. You can kind of see it curving a little bit down here too. So that's why you need to get the whole cervix in view. That's actually also another good sign when you see a curvature. That is suggestive that they're at relatively low risk. Although the main reproducible finding is the actual cervical length itself. So you do want to be careful and not apply excessive pressure, because that can artificially elongate the cervix. And then again, they may have a lower uterine segment contraction, and you want to be careful about that. This one is just, and prior cervical surgery can kind of affect it. Obviously, if you get air bubbles in there, it can affect your visualization. This is just showing a cerclage. This is the posterior aspect of the cerclage, the anterior aspect. And it looks like it's probably good that that cerclage is in place there. So in the Gray Journal in February of 2018, Romero did what's called a report of a major impact, and Romero suggested, based on the large meta-analysis, that it was reasonable, basically, to go ahead and do universal screening and to treat those patients with vaginal progesterone, because vaginal progesterone definitely decreases the risk of preterm delivery. So Stuart Campbell also, in that same Gray Journal, did an editorial and basically said what I just said at the beginning of the slide, that yes, indeed, it's a time for action, and it's a time for us to add to our armamentarium a routine transvaginal ultrasound of the cervix during the second trimester to predict the risk of preterm delivery. So hopefully during this talk, and hopefully it wasn't too long, I helped you to understand a little bit more about the impact of prematurity, which, like I said, you probably already were very much aware of. To understand the challenges that we face in predicting the risk for spontaneous preterm delivery. We don't have any very good predictors. And to understand the evidence behind universal transvaginal ultrasound to screen for the risk of spontaneous preterm delivery. So with that, I'll turn it back over to probably Mashonda or Micah, and happy to entertain any questions that you might have.
Thank you, Dr. Eller, for that. If you have any questions, please feel free to drop those in your chat box, and then he can answer. And as you're dropping your questions, just a quick reminder that you will receive 1 CE for this webinar, but you must remember to complete the survey, and then you will get your certificate in 10 to 14 days. So again, if you have any questions, just type them down in your chat box. I think some people are typing some questions. I'm just waiting for them to come through.
Sure, absolutely. Well, maybe it was clear as mud.
Yeah, so they stopped typing. So again, thank you guys for joining. If you do have questions, just let us know, and we can get them over to Dr. Eller and get those questions answered for you. Again, just as a reminder, HMH, we do have our 45th annual conference that's coming up in October, and also GPA has their 33rd conference that's coming up in September. So please just let us know if you have any questions or concerns. And again, thank you all. And as a reminder, you will receive 1 CE for this webinar, but make sure you'll receive a survey after this to complete that survey, and then you'll receive your certificate in 10 to 14 days. Thank you all.
Thank you very much.
Thanks. Bye.
Bye.